Welcome to the lecture Cardiogenic Shock. We will begin this lecture with a case study and then go into a bit more detail about cardiogenic shock. Imagine you are an intern working in a busy emergency department. Consider the following information given and also the following question. There are a number of possibilities to account for the chest pain. However, this man has presented with the classic findings of myocardial infarction, that is, chest pain radiating to the jaw with a duration of 6 hours. He also has associated abnormal vital signs. Further information regarding past history and medications have come to light. He is triaged as a Category 2 and recognised by the nurse as being unstable, so he's been moved to the Resuscitation bay in ED. You are now seeing this patient and need to decide the next step in his management. Consider the options and the answer will be given on the next slide. Given this is an unstable patient, it is important to remember ABC, that is, airway, breathing and circulation. Assessment and stabilisation of these three areas is the most appropriate next step in managing any unstable patient. Further management can occur when ABC has been attended to. So now the patient has been moved to an appropriate monitored area, has a diagnosis of acute anterior myocardial infarction, and has been appropriately referred to the cardiology unit. However, we have not finished yet. This is the ECG that you have reviewed. It demonstrates ST elevation in the anterior chest leads, which are leads V2 to V6. It also demonstrates ST elevation in the lateral limb leads 1 and AVL. Note that there is reciprocal ST depression in the inferior leads 3 and AVF. A chest X-ray demonstrates acute pulmonary edema, which is a common complication of myocardial infarction. A bilateral fluffy alveolar fluid pattern is noted, projecting from the hilum. Curly B lines may also be seen. On clinical examination, you would expect to find coarse basal to mid-zone crackles. An arterial blood gas has been performed. It demonstrates a simple acid-base problem. Consider your options and the answer will be following. Remember an approach to acid-base disorders and arterial blood gases. First, look at the pH to determine if there's an acidemia or an alkalemia. Then look at the partial pressure of carbon dioxide to determine if a respiratory or a non-respiratory cause is likely, and look at the bicarbonate to confirm your suspicions. This case represents a patient with cardiogenic shock secondary to a myocardial infarction. This is a medical emergency and requires an experienced doctor to manage, but any doctor should be able to recognise the shocked and unstable patient and seek appropriate and timely assistance. So what is shock? Well, shock is the pathophysiological state where there is an insufficient tissue perfusion to meet the metabolic requirements of the body, either by a lack of blood and oxygen supply or by an increase in the demand from the body. Typically, this is classified into 4 groups, the first being hypovolemic, which, as you may expect, one of the causes is hemorrhagic shock. However, other causes may be severe dehydration or the third spacing that can be seen in some abdominal conditions. Vasodilatory shock occurs commonly in sepsis, but also in anaphylaxis and neurogenic shock. Cardiogenic shock is what we're talking about today, and common causes include myocardial infarction, cardiomyopathies and cardiac trauma. And a fourth category of obstructive shock occurs when a patient has a tension pneumothorax. They may have a clinical cardiac tamponade or a massive pulmonary embolus. The basic management principles of any patient in shock is to try and correct the underlying abnormality and then institute some support to allow the patient time to recover. There are a number of disease processes that may cause cardiogenic shock. As we see in the case study, acute myocardial infarction is one. Cardiomyopathy may be acute or chronic in nature. However, it is usually the acute cases that lead to severe shock. Trauma and acute valvular insufficiency are less common causes. Basically, cardiogenic shock occurs when there is an inadequate cardiac output. In an effort to better understand cardiogenic shock and also to manage the patient with cardiogenic shock, it is useful to revise some basic physiology. As stated before, cardiogenic shock results when the cardiac output is inadequate for the demands of the body. Cardiac output is the volume of blood that the heart delivers to the systemic circulation and is usually expressed in litres per minute. It can also be expressed as a cardiac index, which is what you'll often hear referred to in intensive care. This basically is the cardiac output index to the body surface area and allows easy and quick comparisons between a smaller, shorter person and a larger, taller person. Some basic physiological calculations that are useful include cardiac output, which is simply the product of the heart rate by stroke volume. In turn, stroke volume is determined by the preload, afterload and cardiac contractility. When we look at the oxygen delivery to tissues, we can actually determine this by a simple equation, which is the cardiac output multiplied by the hemoglobin by the saturation by a multiple of 1.38 and also multiplied by a small percentage of the partial pressure of oxygen. Although this seems like a complicated equation, the important part is to actually look at the components that determine the delivery of oxygen to tissues. That is, the cardiac output, the hemoglobin, and the saturation of oxygen in the blood. Note that the partial pressure of oxygen in the blood is actually a very small component of what the oxygen delivery to tissues is. History and examination may also suggest the cause of the cardiogenic shock. Specifically, look for fever, chest pain, family history, and inquire about long-term heavy alcohol use. Careful examination for a new murmur and signs of endocarditis should be undertaken if this is a suspected diagnosis. Initial blood tests include electrolytes, renal and liver function. Arterial blood gases often reveal a lactic acidosis. A septic workup for endocarditis is warranted in some cases. Pulmonary edema may be seen on a chest X-ray, which should be performed early and in all patients. Serial ECGs should also be performed because often the changes are very dynamic. When looking at investigations, an early echocardiograph is perhaps the most important investigation to perform and can even be done in the emergency department. The reason for this is that it can look for most of the causes of cardiogenic shock and also grade the severity. In some cases, coronary angiography is considered quite early, as revascularising a coronary stenosis may improve cardiac function dramatically. In rare instances, further investigations such as a cardiac biopsy may be undertaken, although this would be performed at a specialist heart failure and heart transplant centre. When considering differential diagnosis for cardiogenic shock, think of the 4 broad categories of shock that we reviewed earlier, namely hypovolemic, obstructive and vasodilatory shock. You may need to investigate and exclude these causes if it's not clear that cardiogenic shock is the reason that your patient is shocked. When managing the shocked patient, remember again ABC, airway, breathing, circulation. Organ support is commenced until the initiating cause can be identified and treated. Resuscitation involves assessing and stabilising airway, breathing and circulation, in that order. It is usually a team effort and involves experienced nurses and doctors. It is also usually carried out in appropriate situations such as the resuscitation bay in the emergency department or the intensive care or coronary care. Remember that intubation and ventilation may assist the patient in decreasing the work of breathing and also decreasing respiratory oxygen demand. When giving a fluid bolus for resuscitation, beware the patient in pulmonary edema. Often a smaller bolus is used, for example, a 250ml bolus of saline, rather than the larger boluses that may be used in hypovolemic shock. Once you have a reason for the shock, you can start targeting your treatment. The management of cardiogenic shock can involve intensive care specialists, cardiologists, cardiothoracic surgeons and cardiac anaesthetists. Timely reversal of the problem gives the best chance of survival. For example, if the patient has an acute myocardial infarction, it may be worth considering early coronary angioplasty or even emergency coronary artery bypass surgery. If infective endocarditis and acute valve lesion is causing the problem, they may require urgent surgery to remove the valve. In case of septal rupture, which can follow trauma or even myocardial infarction, again, cardiac surgery is warranted. These are just some of the examples of treatment of cardiogenic shock. While waiting for the initial problem to resolve or be corrected, cardiac support is instituted. There are a number of modalities that may be used to support the patient in cardiogenic shock. First one we will consider is pacing, which is by a temporary pacing wire inserted usually into the jugular vein, and the tip sits in the right ventricle. As we have noted before, cardiac output is the product of heart rate and stroke volume. So by increasing the heart rate in this instance, we may be able to increase the cardiac output. The second category is probably one of the most commonly used categories of supports, that is inotropes and vasopressors. These are specialised medications that need to be run in a special setting where there is monitoring and people skilled in their use. They have to be run by a central venous catheter because their half-life is short. When we talk about inotropes, we're referring to medications that increase the contractility of the myocardium. Chronotropes are medications that increase the heart rate. In practice, a lot of inotropes also have some chronotropy. Inotropes can be further categorised into those which cause vasoconstriction or are called inoconstrictors, and those which cause vasodilatation, which are inodilators. Sometimes there is confusion between inotropes and vasopressors. Vasopressors are medications that are similar to inotropes, but their main effect is systemic vasoconstriction. Therefore, they're used in causes of vasodilatory shock. An example is noradrenaline. Again, vasopressors are usually run through a central venous catheter as an infusion. Looking at specific inotropes, we'll firstly look at adrenaline, which is an inoconstrictor. It acts via adrenergic receptors with a major effect via the alpha-1 receptors of the vascular smooth muscle, resulting in vasoconstriction, and also the beta-1 effects on the myocardium, resulting in inotropy and chronotropy. A number of side effects make its ongoing use less desirable. These include a propensity to tachyarrhythmias and also a lactic acidosis. Dobutamine is an inodilator. It is a synthetic catecholamine. Its main effects are via the beta receptors. The beta-1 effect leads to inotropy and chronotropy, similar to adrenaline. However, the beta-2 effect leads to vasodilatation. Again, a main complication is a tachyarrhythmia. Milrinone is a slightly newer inotrope and is also an inodilator. It works differently to adrenaline and dobutamine. However, the end effect is similar to dobutamine. There is a potential benefit in milrinone in that it's thought to improve relaxation or lusitropy of the myocardium, and it also causes pulmonary vasodilatation, which can be useful in causes of pulmonary hypertension or right heart failure. Levosimendan is quite a new inotrope. It works differently to the others in that it's a calcium sensitizer, and also it is run as an infusion. However, its benefit lasts many days to weeks. It is not at the moment considered a first-line agent in cardiogenic shock, but may be used in some more stable patient with heart failure. As mentioned earlier, vasopressors are medications that cause vasoconstriction. The two main vasopressors used are noradrenaline and vasopressin. A vasopressor is sometimes required in cardiogenic shock to offset the effects of the inodilators. Noradrenaline is usually preferred as vasopressin has been linked to worsening coronary artery disease in the short term. Noradrenaline may also possess some minor inotropic action at very high doses. An escalation in cardiac support may be required if inotropes are failing. Usually the next step would be insertion of an intra-aortic balloon pump. This device, usually placed by a doctor of adequate experience, mechanically supports the heart. It inflates in diastole, augmenting coronary blood flow, and deflates in systole, decreasing afterload. Further support may be added in the form of extracorporeal membranous oxygenation or an ECMO device. This is very similar to a cardiac bypass machine used in cardiac surgery and can basically act as a temporary support for the heart and lungs. Common complications of this device include bleeding and infection, and again, it's only used in certain settings by people experienced in its use. If cardiogenic shock occurs in a younger patient, there may be an indication for cardiac transplant. Because of the waiting time for a transplant, an artificial heart, known as a ventricular assist device, may be implanted. Technology is improving all the time to improve these devices in the hope that they may be a long-term alternative to cardiac transplant. Despite all support available, mortality rate from cardiogenic shock is very high. This is particularly true in the 75-year-old plus age group, where the mortality rate approaches 100%, even with measures such as emergency coronary artery bypass surgery or percutaneous intervention. However, it is important to recognise that for a number of patients, these interventions may be the turning point in their recovery from cardiogenic shock if undertaken early enough. And with advances in technology, such as ECMO and ventricular assist devices, some patients survive long enough to receive a heart transplant and can return to near normal living.